Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenters are Dr. Prasad Kilaru and Mark Neves. Dr. Kilaru completed his medical degree at Guntur Medical College in India. He finished his general surgery training at Bay State Medical Center in Boston and completed his plastic surgery residency at the University of Southern California. Dr. Kilaru completed a hand surgery and microsurgery fellowship at the Southern California Orthopedic Institute and the University of Southern California. He is certified by the American Board of Plastic Surgery and the American Board of Surgery. Mark was born and raised locally and attended school in Fremont. He completed his formal education with a master's degree in occupational therapy in 2007 from San Jose State University and has been certified by the California Board of Occupational Therapy. He has been working at the Washington Outpatient Rehabilitation Center for more than 8 years now, specializing in treatment of injuries to the upper extremities.
Thank you all for coming. I wanted to talk about the nerve compression disorders of the upper extremity. It's a very broad topic, and there are a lot of things that cause problems in the arms. And today we're just going to concentrate on how nerves that are in the arm are affected and the symptoms that are associated with that and how we treat that. Just to kind of go over the agenda, we're going to talk about some of the basic anatomy that we would see, the mechanism of action of how the nerve compression works, how we diagnose it, how we treat it, and also importantly, how do we prevent this from happening and how do we educate both the patients as well as providers in making sure that these things don't happen, or if they happen, to catch them early and treat them early. So briefly, a little bit about the anatomy. There are three main nerves that come into the arm and supply the nerve supply to the arm. There's one nerve coming across here called the median nerve, and that comes right down the middle, and it supplies the sensation to the thumb, index, middle, and kind of half of the ring finger. There's a second nerve called the ulnar nerve, which comes also down from the, all of them start in the neck and kind of work their way down. This one goes behind the elbow and then comes in front of the elbow and comes down like this and supplies sensation to the small finger and kind of half of the ring finger. And then the third nerve is called the radial nerve, and that's present in the back of the arm. So it goes across the back of the upper arm, comes down through the forearm, and supplies sensation to kind of the back of the hand. So all three of those nerves are what we call mixed nerves, meaning they have both a sensory component, meaning that's what lets us feel, and a motor component, which is that's the nerve that controls the muscle movement. So for the median nerve, the main nerve that comes across the front, it's the nerve that's responsible for the big muscle movements in the hand, making a fist, moving the wrist, things like that. The ulnar nerve is responsible for the small muscle movements in the hand, playing a piano, typing. The fine movement that we see in the hand is related to the ulnar nerve. And the radial nerve, which comes across the back, is responsible for the movement of the back of the arm. So lifting the wrist, lifting the fingers, those kind of movements are involved with the radial nerve. So when there's compression or irritation of the nerves, then the associated muscles or sensation is affected. So we're really concerned about sensation and movement in the hand. So going back down to the hand, if you look at the front of the hand, so this part here, thumb, index, middle finger, and part of the ring finger, that's the median nerve. When carpal tunnel syndrome or anything like that happens, that's the nerve that gets affected. The ring finger and the small finger is affected by the ulnar nerve, both the front and the back. So this is the back of the hand, this is the front of the hand. So the ulnar nerve is here, and in the blue you can see that's the ulnar nerve. Median nerve is in the front, and then the radial nerve is in the back. So those are the areas where we see where the nerves are distributed. So depending on which nerve is affected, they're called by different names. So the most common nerve to be affected is the median nerve. And the symptom that's associated with that is what's called carpal tunnel syndrome. And I'll get into more detail about that. And the median nerve can be compressed in a bunch of different areas, but the most common area where it gets compressed is at the wrist. The ulnar nerve, remember I told you goes around the elbow and comes up to the front, can get compressed either at the elbow or at the wrist. And the radial nerve, which is the third nerve, can also get compressed, but luckily that's pretty rare, and I'll explain that as well. The compression can happen in one of two different ways. The nerve is usually protected because it's an important structure. The body tries to protect it, so it's usually present in a small compartment or a tunnel or things like that. So if the other contents in the tunnel get bigger, they put pressure on the nerve. Or if the tunnel itself gets smaller because of arthritis or trauma or anything like that, that can also put pressure on the nerve. When you have that pressure, then you have symptoms related to the pressure on the nerve. The earliest symptom that we usually see is numbness, because the nerve is basically a glorified electrical wire that's connecting the fingers to the brain. And when the nerve is not working properly, then it's not sending the signal to the brain as quickly as it normally would. And the brain perceives that as numbness. As the pressure continues, then the blood supply to the nerve starts getting cut off. And when the blood supply starts getting cut off, then the body perceives that as pain. Similar to any other part where the blood supply gets off. So if somebody's having a heart attack or chest pain, there's not enough blood going to the heart. If somebody's having poor circulation and leg pain, there's not enough blood going to the leg. Similarly, if there's not enough blood going to the arm, then you can have nerve pain. Now the nerve, as I mentioned, starts in the neck and goes all the way down to the fingers, so you can have pain radiating up and down pretty much anywhere along the whole length of that nerve. So it's not unusual where you may have just carpal tunnel, which is a problem in the wrist, but there may be pain shooting up and down along the whole length of the nerve. If the pressure continues, as the blood supply to the nerve starts getting cut off and we're not treating it, then the nerve can start to die. And we don't want that to happen, because once a nerve dies, it doesn't come back to life. And that's why when somebody's paralyzed, they don't get up and walk again, because once the nerve is dead, it's dead and we can't really fix it. So whatever we try to do, we want to do before we get to the point where the nerve is dead. Now the numbness is related to the sensation part. I also remember I told you all three nerves are mixed nerve, meaning they also control the muscle. And if there's enough pressure, then the muscle also starts getting affected. And then you start having weakness in the muscle. You're dropping things because the muscle's not working as well as it could. Or it's getting weaker faster, so you're not able to do things as long. You get tired faster or weaker, and that's the other thing that we want to prevent. So how do we diagnose the nerve compression? A lot of it is just doing a good examination, taking a good history. So talking to the patients and seeing what the problems are. And usually we can get a pretty good diagnosis just based on that. But there are also clinical signs that we can test to look at where the compression is, try to identify the compression. And finally, there are tests that we can do. The nerve conduction study, which I'll explain in a little bit, which also helps us to tell if the nerve is working properly or not. Once we've kind of come with a diagnosis, either from the examination or from the nerve test, the next step is to try to treat the problem. Now, any treatment we do is always two steps. We do the non-invasive, the simpler stuff first, and if that doesn't work, then we move on to more complicated steps. So the non-invasive step, pretty much for any repetitive problem in the hand, not just nerve compression, but tendinitis or anything like that, starts with rest, anti-inflammatory medication, physical therapy, and if those don't work, then we kind of move up the chain as far as what we can do next. So rest. Whenever you're using a body part, the more you use it, the more that can potentially get irritated, potentially get swollen, so we want to limit that. In certain areas, especially the wrist, we can use a brace to kind of prevent you from moving the wrist too much and rest that area so that you're allowing that inflamed part to kind of rest. Second is anti-inflammatory medication. There are a whole bunch of different kinds of anti-inflammatory medication: Motrin, Advil, Aleve, Naproxen, and steroids. They're all different medicines that help decrease inflammation. They also help with pain. And a mistake that a lot of people make is when they're in pain, they take the medicine, but when they're not in pain, they don't take the medicine. That works great for pain, but it doesn't work as well in decreasing the inflammation. The inflammation took a certain amount of time to get to the point where it's causing pressure on the nerve or causing pain or anything like that. So it's unlikely that 1 or 2 doses or 1 or 2 days of the medication is going to bring that inflammation back down to a normal level. So what we want to do is try to take the medication on a more consistent basis to kind of bring the inflammation down. And the other thing is physical therapy, which works in conjunction with that, because what we want to do is, again, decrease inflammation. And there are a whole bunch of different modalities that we do in physical therapy, and Mark will kind of get into that in more detail as what we can do in decreasing the inflammation, looking at what our work situation is. If you are working on a laptop with your fingers bent and your elbows up like that, you're more likely to have problems because the body's not designed to work like that for 6 or 8 hours or what have you. And so we want to make sure we're in a position that's putting the least amount of stress on the different body parts to prevent them from getting irritated too much. If the simple stuff like the anti-inflammatory medication and the therapy and all this stuff doesn't work, then we go into more invasive options. The two invasive options we have are steroid injections or surgery. While we can give steroid injections in other areas of inflammation, I'm not a big fan of giving injections to the nerve or close to the nerve, because most of the time it's a blind injection. And if we were to inject the cortisone into the nerve, that can cause permanent damage. Luckily, it's pretty rare, but if it does happen, it's something that we can't reverse. So I usually don't like to do that. So if the simple things like the braces and the therapy and the medicine doesn't work, then I usually talk about surgery. Surgery is very effective. It's a cure in that it relieves the pressure on the nerve and it prevents the compression from getting any worse. But again, it's always the last option when we've tried everything else and nothing else has worked. Whenever we have any kind of compression, whether it's tendinitis with compression or whether it's the carpal tunnel syndrome or other problems, what we want to do is we want to relieve the pressure where it is. And most of the time by doing surgery to open up the pressure, it makes it go away. Now with the nerve compression, what I tell my patients is, once we've relieved the pressure, we're going to make sure there's no additional pressure on the nerve. But I'm not going to be able to bring back any nerve fibers that are already dead. So if we do surgery, you're most likely not going to get any worse. And how much better you get depends on how much damage there is to the nerve. The nerves, unfortunately, are pretty slow to recover. So it may take up to a year for the nerve to recover. So in patients that have carpal tunnel syndrome, I tell them at the end of the year, whatever numbness, pain, weakness you have is what you're going to have for the rest of your life. But up to that point, you can continue to see improvement because you are releasing the nerve and the nerve's kind of recovering from the damage that's there. The longer you had the symptoms, potentially the more damage there is, the longer it takes for the nerve to kind of recover. Three common ones, like I said, that we see are compression on the median nerve, compression on the ulnar nerve, and rarely compression on the radial nerve. If you take 100 people that have nerve compression, 90 plus will have compression of the median nerve. About 9 to 10 will have compression of the ulnar nerve, and less than 1 in 1,000 will have compression of the radial nerve. So it's a relatively uncommon condition. But the carpal tunnel is the most common condition. So the carpal tunnel syndrome occurs usually at the wrist. At the wrist, there are 8 bones that make up the wrist joint. So this is what's called a transverse section. If somebody was to take a knife and kind of cut across this area, this is how it would look. And you have the 8 bones that form a little C-shaped cup, and across the top, there's a ligament. So you have the cup like this and a ligament across the top. So this is a tunnel. Greek for carpus is wrist. So carpal tunnel is basically a tunnel at the level of the wrist. Through this tunnel, you have 9 tendons, 2 for each of the fingers. One that lets you bend here, one lets you bend here for each of the fingers, and there's only 1 knuckle for the thumb, so 1 tendon here. So you have these 9 tendons and 1 nerve. And that nerve supplies sensation to, like we talked about before, these 3 fingers and half of this finger. Now, with repeated use, overuse, trauma, diabetes, any of these conditions, the tendons swell up. It's not the nerve, it's the tendons that swell up. And when the tendons swell up, they push up against the nerve. And when they push against the nerve, that's how the symptoms start to develop. The compression can happen in 2 ways, like I said. It can either be because of swelling within the tunnel or something going on the outside that makes the tunnel smaller. So most often it's a swelling within the tunnel, and it's usually related to repetitive use. So again, most common reason is repetitive use, whether it's computer work, whether it's assembly line work, whether it's farming. We see it pretty much in anything where you're doing the same thing over and over and over again. The tendons swell up and they put pressure on the nerve. The way I explain it is, say you have a room or an elevator that can fit 10 people, each one 150 pounds. If 9 people leave and 9 300-pound people get into the elevator, that 10th person is going to get squished because the elevator is only a certain size, and if everybody else gets bigger, there's only so much room for that last person, and that puts pressure on that last person. There are other reasons why you can get swelling. If there's fluid retention, most common reason is during pregnancy. low thyroid function, diabetes, or rheumatoid arthritis or anything like that, all of those conditions can increase the amount of fluid that's present in the compartment, and that can cause problems also. And finally, this is luckily relatively rare, but if you had any kind of injury to the wrist, and the bone's broken, or there's arthritis, and the outside of the tunnel, this part swells up or pushes in, that can also cause pressure on the nerve as well. And that's usually more emergent because it's usually related to trauma and that we need to kind of fix sooner than later. And what happens is once that swelling starts, you get what I call a positive feedback loop. There's swelling that causes discomfort, and the body's response whenever there's discomfort is to say, hey, there's something wrong, let me send more blood and fluid to that area, try to get it to heal. And the body sends more blood and fluid, and that causes more swelling, which causes more pressure, which causes more pain. So it's like a snowball going downhill. That swelling pain, that cycle just keeps going. Even though the original insult, the original trauma has gone away, this process continues to go on. And depending on how quickly we stop it, that determines how bad it gets. The symptoms, once we know that you have carpal tunnel, are very similar to what we talked about before. You start off with numbness in these 3 fingers. What we found is the tunnel is its widest when the wrist is straight. When you bend the wrist this way or this way, the tunnel tends to get narrower in one direction or the other. When you are sleeping, if you have a tendency to sleep like this or sleep like this, you're keeping the hand in an awkward position, compressing the tunnel for 6 or 8 hours or however long you sleep, and that tends to make the discomfort worse. So typically what happens is you fall asleep, there's a little bit of numbness, you really don't notice it, but when you sleep in that awkward position, the numbness turns to pain, the pain gets worse to the point where it finally wakes you up. And when you wake up and you kind of move the arm, massage the area, and that gets the circulation back, and then you feel better. It's a very classic, very common history and symptom that we see in anybody who's got carpal tunnel, that feeling that, oh, my hand's fallen asleep and it's waking you up at night. If that continues, then, as I mentioned, then you start having pain during the day also. And the reason that the brace, when we start using it at night, helps with the pain is that you're preventing the wrist from going into that awkward position, and that prevents you from irritating it and making it get worse. If we've tried the basic things and it doesn't seem to be helping, then the next step is to do what's called a nerve conduction study. A nerve conduction study tells us how well the nerve is working. It doesn't tell us if the nerve is alive or dead, it just tells us how well it's working. The way I explain it is, say you're outside this building, and you know this building has 1,000 lights. And if you sit outside and you can count from the outside, and you can say, okay, I can see 1,000 lights, I can count 1,000 lights, then you know, okay, everything's working okay, there's no problems. If you're sitting outside and you can only count 800 lights, then you don't know if the other 200 lights are broken or if somebody's just turned the switch off. It's the same with the nerve test. It says, okay, 800 are working, but it doesn't say the other 200 are dead or just compressed and not sending the signal like they normally should. But intuitively, you know that if 200 lights aren't working, it's probably not that bad. If 500 lights aren't working, it's probably a little bit worse. If 800 or 900 lights aren't working, it's probably a lot worse. So the nerve test tells us that. It tells us, okay, is it a mild or is it a moderate or is it a severe compression, depending on how quickly the nerve is responding. The way we do the test is we put electrodes along the arm and we send a signal. We do a little zap here and we see how long it takes for the signal to come up to the neck. And say normally it should take 10 seconds. This part should take 2 seconds, here 2, here 2, here 2. But instead of 2, if this part takes 4, then we say, okay, the problem's at the wrist. If all of this is 2 and this part takes 4, then we say, okay, the problem's at the shoulder. So by that way, we can determine where the problem is. And by whether it's 2 seconds or 4 seconds or 8 seconds or 10 seconds, we can tell, is it a major compression or a minor compression or something that we can watch or whatnot. So the nerve compression test does 2 things. It tells us how severe the compression is, and it also can tell us where the compression is, because as I mentioned, there are different areas where you can get the compression happening. These are some of the tests that we use to see if the nerve is irritated. These are what we call provocative tests, meaning when you're resting, the nerve may not be too irritated, but if we do things to kind of irritate the nerve, that shows up. So this is a very common test where we basically kind of bang over where the nerve is on the outside. It's similar to if you hit your funny bone. If you accidentally hit the funny bone the right way, you get this electric shock going down into the fingers. So we simulate that by hitting it where the nerve is close to the skin, where we know where the anatomy is, and kind of tapping it. And more than a pinching, it's actually a tapping mechanism like that kind of tells if there's a little electric shock going. And we can do that in different areas. So for the wrist, common area is here. For the elbow, we can do it up here. For the shoulder or neck, we can do it across this area. So different areas depending on where the nerve is closest to the skin. This is another common test, and it's similar to what we're doing when you're asleep. If you're bending the wrist in an off position one way or the other, that recreates the symptoms, and that's what we're doing. We're kind of bending the wrist and keeping it in this position for anywhere from 30 to 60 seconds, and if that reproduces the symptoms, that's again a good marker that it's similar to what carpal tunnel is. And as I mentioned, as the muscle starts to waste, if you look at your hand, this muscle has a certain degree of volume to it, and if you notice that one side's kind of wasted compared to the other side, that's because the muscle's irritated or damaged, and that's a late symptom. We don't want to wait till we start seeing that before we say we got to do something, because that's pretty late in the process. Again, once we diagnose the compression, the treatment is still the same, especially when it's work-related, when it's involved with computer use and things like that. A majority of my patients were able to control by making sure that they have a good workstation, that they're not sitting out of proportion to where they should be. I mean, ideally, when you're working on a computer, your elbow should be at 90 degrees, your wrist should be slightly elevated. So if your chair is too high or too low, that can increase the risk of problems because you're sitting in one position for a long period of time. If your hands are turning in because you're working on a small keyboard, or out too far because it's too large a keyboard, or using the mouse a little too much, all of those can contribute. So we want to make sure that where you are working, and it doesn't have to be at work, even if it's at home. If you're doing a lot of work on the computer, you want to make sure that you're raising or lowering the chair so that you're in a comfortable position, because if you do that for a long period of time, this slowly builds up and starts to cause problems. And then again, like we talked about before, anti-inflammatory medication, braces work really well in controlling the symptoms, especially if we catch it early. Physical therapy is another thing that works well when caught early because it helps decrease the inflammation in the area. And the other thing that Mark in the physical therapy department does really well is kind of training you how not to do something. Because it's like any other habit. You get into a habit of doing certain things a certain way, and they're not necessarily always the best habit. Sometimes they're just the easiest way to do it, and a lot of times the easiest way is not necessarily the best way to do it. And so they help retrain us on how to use the computer, the mouse, even the pen in a proper way so that it doesn't cause the symptoms. If all we've done of these and they don't work, then we talk about surgery. The surgery is a very simple operation. From the time I make a cut till that time I say, hey, wake up, you're all done, it takes about 10 minutes to do the surgery. And it's an outpatient surgery. You come in, you have it done, you're able to go home the same day. And we can do it with you asleep or you awake and just a hand asleep. Either way is perfectly fine, it's perfectly safe. What we do is basically we release that nerve by releasing the ligament. We don't make this big an incision, this is just to kind of show you. The incision is typically about an inch long right in the palm. And what we do is we go in and release the nerve in that area. Once we release the nerve, I'm able to see the nerve. I'm also able to see the contents of the carpal tunnel, those 9 other tendons that are there. And as I mentioned, a lot of the times those tendons are swollen. There's a lot of extra lining and inflamed tissue all around those tendons, which is putting pressure on the nerve. So once we release the tendon, then what we do is we move the nerve out of the way and we clean out the tendons to get rid of all of the extra inflamed tissue so that now there's more room in the tunnel. So going back to that elevator example, it's like breaking open the door and taking out all the 300-pound people and putting back 150-pound people. So we've made the room bigger and we made the contents of the room smaller, so that decreases the chance of the carpal tunnel coming back. It's extremely rare for the carpal tunnel syndrome to come back once you've had surgery. If it does come back, it's usually 10 or 15 years or later down the road, because basically, you had a small tunnel, we made the tunnel bigger. Well, if you keep using the hands, these tendons can slowly get bigger again, and then they have to get bigger again, enough to push on the nerve and cause symptoms. So that's usually pretty rare, and if it does happen, it takes a while for that buildup to happen. So it's usually 10 to 15 years, if not longer, down the road. There is also an endoscopic way that we do the carpal tunnel, which is we make a little cut about a ½ inch at the wrist level, and through there we go in and just release the nerve. Not everybody is a candidate for that, because we need to be able to look at the other contents in the tunnel to get rid of the extra lining in the fluid and whatnot. So certain patients where they haven't had symptoms for a long period of time and when there's not a lot of overlap of tissue, then it's an option. But long term, either way we do the surgery, the recovery is the same and the patients do just as well with either option. That's about the carpal tunnel. Now, the ulnar nerve compression is a very similar story, just different locations. So you can have the ulnar nerve compression either at the elbow or at the wrist. At the elbow, it's called cubital tunnel syndrome. Cubitus is Greek for elbow. So cubital tunnel syndrome is basically a tunnel at the elbow where the nerve is compressed. The nerve goes behind the elbow and comes forward. And if you look, when it goes behind the elbow, when you're bending the elbow, that puts more stress on the nerve and more stretch on the nerve. So what we want to do is try to limit that. The mechanism, everything else is still the same. Repeated use causes swelling, compression on the nerve, pain, numbness, what have you. With the carpal tunnel, it was bending the wrist this way or this way. With the elbow, when you bend the elbow this way, answering the phone, driving, sleeping like this, that causes pressure on the nerve, wakes you up, da-da-da. With the carpal tunnel, we use the brace at the wrist. For the elbow, people have tried putting a brace at the elbow. Most patients don't like that because you feel like you're in a straitjacket. It's tight, it's hard to sleep that way. So what I usually recommend for my patients is to take a towel, like a bath towel or something like that, and then wrap that around the elbow like that. So because that's a little bit softer, it allows for some flexion, but it doesn't allow you to go all the way because that kind of helps hold it in place. And most of the time that works in helping decreasing the pressure on the nerve. And also during the day, trying our best, especially if you're answering the phone, to use a headset as opposed to doing this, whether it's a cell phone or the landline, things like that to help decrease that pressure on the elbow helps. And then similar to the carpal tunnel, the rest, the anti-inflammatory medication, and things like that. Now, if that doesn't work, the treatment is still the same. We get a nerve conduction study, just like with the carpal tunnel, where it tells us where the compression is. The ulnar nerve can tell us if the compression, nerve conduction study can tell us if the compression is at the elbow or if it's the compression at the wrist. And depending on where it is, we kind of address it the same way. Just like with the carpal tunnel, I don't like to give cortisone injections close to the nerve because, again, if you inject into the nerve, you can cause permanent damage to the nerve. The surgery for the elbow is, again, very similar. You're relieving the pressure on the nerve. So you're kind of taking the nerve out of the tunnel that it was in. Once you've taken the nerve out of the tunnel, it's kind of sitting in this location, but it's still susceptible to bending and stretching when your elbow is bending and whatnot. So in patients where they have a prominent elbow or when you're bending, the nerve seems to be stuck in that bent position, we actually move the nerve to the front. So when we move it to the front, now whether you bend or straighten it, you're not pulling on the nerve, so there's less likelihood of causing discomfort in that area. When you move the nerve to the front, there are two locations where you can move the nerve. You can put it in what's called a subcutaneous plane, so sub-undercutaneous skin, so just under the skin, or you can put it in what's called a submuscular plane, which is under the muscle. Both of those have advantages and disadvantages. The muscle has better blood supply, there's more protections. If you can put it underneath the muscle, it's a safer, better protected nerve. But it's a bigger operation to cut the muscle, put it underneath, and then wait for the muscle to heal and whatnot. Most people have enough kind of skin and fat where there's enough of a cushion that it's usually not a problem. So the majority of the time when we do the surgery, we move it and put it underneath the skin and fat, and it does pretty well. It's rare, less than 1 in 20, where I have to convert somebody from above the muscle to below the muscle. And it works well in decreasing the pressure on the nerve, improving the symptoms. Now, because the ulnar nerve is further away, recovery from that can take longer. You can see improvement for up to 2 years because it's a little bit further away than it is from the wrist. And same thing again, as you recover, you still want to make sure that you do therapy and exercise and stuff to maintain the movement and the strength and everything else that you had during that time. Now, the ulnar nerve release at the wrist is pretty much the same operation as the carpal tunnel. We make a very similar incision. We go down, because the carpal tunnel, the ulnar nerve and the median nerve are pretty close to each other. So we release both the nerves at the same time when we're doing ulnar nerve release at the wrist. Now, the radial tunnel, as I mentioned, is that third nerve that goes across the back of the arm. The compression for that is pretty rare. And what happens with the radial nerve is it usually doesn't go through a tunnel. It goes between muscles. Overuse, these muscles can sometimes crisscross across each other and put pressure on the nerve. That causes the pressure on the nerve. Because the radial nerve is not that much sensory, it's mostly motor, you get more of a dull ache, like a muscle ache across the back of the forearm that is not really related to numbness per se. It's more of an achy pain that you feel on the back of the forearm. Movement, lifting the wrist or moving the forearm causes that pain to get irritated because those muscles are then rubbing against each other and pushing on the nerve and causing irritation. Now, the nerve conduction study is not always as diagnostic because it's not a compression. It's related to more movement. So if you weren't moving when you do the nerve test, you may not have a noticeable deficit on the nerve conduction study. So a lot of times the thing that works best in trying to figure out whether that's what a patient has or not is to actually do a block, to put a little bit of Novocaine in that area where the pain is. And if the pain goes away and the nerve starts behaving normally, then we know, okay, the irritation is related to that area. It's rare that we have to operate on this, because most of the time, because it's muscle movement and muscle irritation, physical therapy, anti-inflammatory modalities, stretching, things like that will definitely help in kind of making this better. And then another condition which is pretty rare, I mean, I see it maybe once a year at most, is what's called thoracic outlet syndrome. Now, all of the nerves, remember I told you they all start in the neck and they kind of work their way down into the arm. So when they come from the neck down into the arm, they go through what's called the thoracic outlet, this part of the neck area, before they go into the shoulder. So this is a relatively tight area. You have muscles there, you got the blood vessels that are going into the arm coming up there, a little bit of the lung comes up there, the top part of the lung comes up there. So all of those structures are going through, it's not a tunnel per se, but a larger area, but there are a lot of structures. So there's a potential that you can get some compression over that area, either because of some anatomic deformity, like an extra rib or a muscle that's a little bit larger than it needs to be, and things like that. And that's a relatively rare condition, but most of the time that's something that, again, can be treated with physical therapy or exercises rather than having to do surgery or anything like that. With any of these conditions, once we've diagnosed it, we know how to treat it. A lot of the times, if you know what to look for, you can catch it early and treat it early before you get to where there's a problem that we need to fix surgically or with something more fancy. I tell my patients this, that our body is not designed to work on a computer for 8 hours a day or in an assembly line for 8 hours a day. If you are running a marathon, marathon's 4 or 5 hours, and whether you're running your first marathon or you're running your 100th marathon, you're going to stretch. You're going to get up, you're going to warm up, you're going to stretch, and after you're done with the marathon, you're going to cool down. It's not like somebody just gets out of bed, runs 26 miles, and then comes back and goes about doing their business normally. For the small muscles in the hand, whether you're typing, writing, doing any of these things, it's a marathon. We don't think of it that way because our body's used to doing it for so long, but it is a marathon. And once they're injured because of repeated use or whatever, then we do need to kind of baby them a little bit. So I tell my patients, you have to stretch before you start, icing the area down, warming up. After you're done with work or even during work, icing the area down. If you notice a symptom, then you want to treat it, right? A lot of times I have patients, oh, it hurts a little bit, but I want to finish this page. I want to finish this chapter. I want to finish this project. We don't want to be doing that. We want to stop, stretch, and proceed. If we don't do that, then it will continue to get worse to the point when it becomes symptomatic where we have to do something about it. So a lot of it is learning how to recognize those symptoms and also learning those preventive maneuvers, whether it's stretching, whether it's the proper positioning of the keyboard or the mouse or those kind of things to kind of prevent those things from happening. And that's what we try to do, whether it's with us or with therapy. Once we've kind of treated the patients, we also want to make sure it doesn't come back. I tell my patients, it's like if you're driving on a road that's got a bunch of nails in it and you get a flat tire, what we do is fix the flat tire, whether it's medicine, braces, therapy, what have you. We're fixing the flat tire. Unfortunately, with life, we're putting you back on that same road that's got the nails and everything. And if you do everything exactly the same way, you're going to get another flat tire. That's the story of life, right? So we want to kind of change what we do so that we can recognize those bumps in the roads or those nails in the road so we learn how to avoid them and hopefully prevent another flat tire from coming. Because I get lots of patients that come in and say, oh, the cortisone didn't work. It's not that it didn't work. It worked. It took care of the problem. But unfortunately, we recreated the problem once again. So we want to see what we can do to avoid recreating the problem. So just in summary, from a physician standpoint, taking a good history, and from a patient standpoint, looking at your symptoms, looking at, okay, what are the things that are making it worse? What are the things that are making it better? What can I do to avoid these? And then, once you identify the symptoms, not ignoring them, right? So whether it's resting them, taking medication, making sure that where you're working is properly set up to be able to do that, and then seeking treatment early so we're not waiting for things to get really bad before we say, okay, we got to do something about it or whatnot. Thank you.
I appreciate you taking the time out of your day, and hopefully we'll be able to enlighten you a little bit more about the therapeutic perspective. Dr. Kilaru did an excellent job explaining the anatomy, so I'll kind of briefly review, and then we'll spend a little bit more time on what perspective we have from the therapeutic angle. So we're talking about nerve compression disorders, and in a greater whole, repetitive strain in general. So as he mentioned, carpal tunnel syndrome, most closely associated with the median nerve, cubital tunnel with the ulnar nerve, and radial tunnel, which he said was much more rare, from the radial nerve. He did a great job of explaining, as some of these pictures show, where the nerves lie and some of the activities which aggravate those nerves, which we'll talk about more in a moment as well. And also, which we didn't mention, but in the repetitive strain, more general sense, again, hand wrists form tendinitis versus tendinosis. A lot of people come in with one or the other and not really knowing which is which. Tendinitis, you see it with the eye, often refers to a more acute phase, so earlier on in the injury, and you'll actually see swelling or inflammation present in the injury area or the inflamed area. Tendinosis is a similar sensory experience, so you'll have pain associated with it, but most people think I need to ice anytime there's tendinitis, which is true, but if you have tendinosis, oftentimes you've had it for a chronic period of time, and that tissue is actually very damaged, scar tissue has formed, most likely not a lot of inflammation present, and therefore you're icing something, it's going to reduce your pain, but it may not be curing the issue at hand, which is the actual tissue damage that has been caused from the repetitive strain. So just a little bit more about some different types of injuries and scar tissue formation in soft tissue. There's more than 3 ways, but the 3 most common ways that you injure your soft tissues are with a traumatic tear. So the athletes that we see, someone who falls down, a little bit more of a traumatic, what we call a ballistic movement, where it's very quick, quicker or more prominent than the body can sustain. Therefore, your soft tissue actually physically tears, much pain associated, a lot of swelling, a lot of inflammation. You're going to know there's a problem right away in that case. Those are a little bit less common. We do see them, like people tear their biceps lifting something too heavy, but not as frequent as some of the other repetitive strain injuries. The second one we see here is more common from the repetitive strain type, like Dr. Kilaru said, the industrial worker from Tesla, which we see often, or what used to be NUMMI, the athlete that does something repetitively, or most commonly we see a lot from computer use. For everything good about technology, there's always something bad, and some of that is the abuse of it or the overuse that our bodies can't sustain that activity level. And what happens is over time, I like to associate it as ropes rubbing past one another. Initially, they'll slide very easily, a lot of lubrication in the body and not a lot of friction. But over that period of 5 or 8 hours where you're doing that marathon, as Dr. Kilaru made the analogy to, you're going to build up heat in that tissue. That tissue is going to swell. Therefore, there's going to be more pressure, more fluid, more inflammation, and then eventually a micro tear or breaking down of that tissue, which again creates that pain cycle, which he alluded to, and that downward spiral. And the third one, which he talked about, is a starvation of oxygen, which produces pain. So a lot of times people just tend to be tense. If you carry a lot of your stress or activity in your shoulders and neck, you're not breathing deeply. Those muscles remain in some level of contraction over a long period of time. They're starving themselves of oxygen, and then eventually you get pain or muscle ache, and what that is the starvation of oxygen producing that pain, and then the muscle tissue breaks down. As the muscle tissue breaks down further, then the body is going to produce scar tissue in those tissues, and it's again a chronic cycle. The more you're tense, the less blood flow, less oxygen, and more damage. An additional thing, as he spoke about, was environmental. So ergonomics is a big key for physical therapy. We promote it all the time. It's actually one of the hardest things to achieve, unfortunately. We're working against basically the environment. The way we work, we try to make every one size fit all because we can sell more of them, or more people can use that particular environment effectively or efficiently. So what we do is we throw one type of keyboard out there for millions of people and expect them all to produce the same way. Unfortunately, we know that that doesn't always work. So as Dr. Kilaru said, if we're working at a station where your elbow is hyperflexed, you're going to put pressure on the ulnar nerve in that case. Or if you're at a desk that's too high and you have to rest or push down on your wrist, that's applying an external pressure on that median nerve. And what we get over a long period of time is, again, a starvation of oxygen, less room, more compression on the nerve, and then those symptoms of nerve compression begin. What we want to stress is, as he said, good alignment, which we'll talk about in a little bit, and making that workstation a little bit more custom to your body size and also your activity. And that way you can either prevent or prolong the symptoms from occurring. In most cases, we want to try and prevent because it's always going to be the easiest way of recovery. So we're going to talk about 3 different phases of injury. The acute phase, which just for our distinction is usually 6 months or less of symptoms. The more chronic phase, which is someone who's had it for over 6 months to years, and then post-surgical phase. So from the therapy perspective, what we often look at for the person that comes in, the first thing we want to do is identify the cause of the injury. If we don't know what's causing it, it's very difficult to prevent it because we're just operating blindly. So we want to identify the cause. We'll try and speak with the patient, get a good history of what their activity level is, what it is that causes pain, what they've been doing when they get pain. Is it only at night? Is it during the day, like Dr. Kilaru mentioned? And what about that? What is the quality of that pain? Is it sharp, dull, those kind of things? That way we can identify some activities that are creating pain or putting you in a harmful situation. We then want to move on to activity modification. So if there's something, a little quick fix, a tweak of an activity, changing the duration of which you do something, something like that, and then we try that over a course of a couple weeks in association with therapy. And if it goes away, then we know that was the problem. If it doesn't, then we can move on further and try and identify more about what's causing that problem. Ergonomics, which again we'll speak more of in a second, but getting your environment to work for you as opposed to you working in that environment. Rest, as we talked about, is very important, especially in the acute phase. Many times people just need a break. We work several hours, as we all know, or we're doing activities repetitively, and sometimes it's just our bodies are overworked, overstressed, and under-rested. So if we could get some rest away from the activity that's causing pain, a lot of times those symptoms will reduce and even in some cases go away completely. Ice in the acute phase, less than 6 months. Again, we're talking about tendinitis if it's associated with the tendon. If it's the nerve, there's probably inflammation present around that nerve. So we can ice it and, as the doctor mentioned, use medication in order to try and reduce that inflammation and also reduce the compression on the nerve or on tissue. Stretching, which is very key in therapy, is stretching and strengthening, as we most know, is kind of our 2 main tools that we use. So keeping the tissues lengthened. A lot of times we just generally are tight, and if you don't have the amount of length or slack, if you will, on the soft tissues, sometimes you're not giving yourself that little bit of margin that you might need in order to withstand a greater injury. Whereas if we lengthen or stretch the tissue, at least you have a little bit of play, especially in nerves, where he said they might get compressed. If we could get some slack in there, as they do with that submuscular or subcutaneous procedure that he was mentioning, if we get a little slack, then you take stress off of that tissue, and most likely it will respond a little bit better or with less irritation. Splinting is another thing in our office that we do. We promote the over-the-counter, which I'm sure everyone's seen, the black Velcro braces. Work terrific in most cases. Again, they're usually kind of the one-size-fit-all, or they have a few sizes, not necessarily contoured to each individual. We also do custom splints in the case that's needed, where maybe an over-the-counter doesn't fit someone quite right. And we use a thermoplast material, customize it to the hand or to the need of that patient. The good thing about custom splinting, which we'll talk about in a little bit, is that you can adjust it in such a way that a person can be a little bit more functional with what they're using. And then the last one, I'm not going to go into depth because medication tends to come from the doctor's side of it. He spoke about steroids, which are sometimes an option, but not so much with nerve compression, but more with repetitive strain or tendinitis. And also NSAIDs, as he mentioned. A big mistake is not taking them in the allotted amount of time that the doctor might prescribe and just trying to spot treat. You'll get a short-term relief, but probably not a relief of the overall injury. The next phase is more the chronic. Unfortunately, we tend to see a lot of people that come in, which we would classify the chronic phase, but also before surgery. Most individuals tend to ignore their pain, unfortunately. So they'll go about their business. They'll notice that the signs and symptoms are beginning, but they'll just continue to work through it because, one, fear of job situation or complaining to their boss, perhaps. Other people just want to deny the fact that there is pain, and if you ignore it, maybe it'll go away. Don't do that, by the way. It never works. And usually what happens is it gets to a point where it's so bad and it's not really getting any relief, and then they present to the doctor saying, I've had this problem for over a year. It's finally gotten to the point where I either can't function or it's just causing me pain. I can't sleep is a common one. When people start losing sleep, they'll start to notice it a little bit more. The problem with that is that oftentimes something that would have been much easier to reverse early on has now become a chronic condition, and we've gone from that acute inflammation to now more chronic and soft tissue breakdown. That's a little bit harder to reverse once you get to that point. It takes a much longer period of time for your body to recover from. It is possible in many cases. It's just the expectation for many people is that it's going to go away fast, and usually at that point it's going to be a longer recovery. It no longer requires ice in this case, unless it's just for pain relief, because the ice is no longer going to have an effect on inflammation, because that inflammation is not usually there. Stretching is still very important because we want to make sure that those injured tissues that are developing scar tissue remain very flexible and limber, and oftentimes what doctors will see is that the tissue has actually become more leather-like and less elastic. And the less elastic your tissue is, the less flexible you are, and you're going to start limiting your body's potential that way. And then exercise, of course, which we'll speak about the difference between eccentric versus concentric, but being able to strengthen those tissues back to be able to withstand whatever physical activity your body requires is very important. And then the third stage is post-operative. So if you had to get to the point where we couldn't successfully rehabilitate you without surgery, Dr. Kilaru comes in and does a great job. Smaller incision than what he showed. That was a little scary picture, but it's not that bad, I promise you. And then what we're looking at is either an assessment if it's the first time we've seen you, or if we did some therapy, it didn't work, and then we had you go in and they surgically corrected the issue, the compression, we would do a reassessment. So we want to see where you're at before the surgery, and then now where you're at now. Oftentimes, you'll be much more functionally limited coming out of the surgery initially than you were before, because even though you were having pain, most of the time, functionally, you're doing fine. You can still grip things in most cases, lift things. It's just uncomfortable. After the surgery, there's going to be a period of rest, and we need to assess your level of function and independence. Initially, we want to worry about wound care, the edema process, getting the swelling down from the surgery itself, and then also in infection prevention. We want to make sure that there's no outside bacteria or infection getting into the wound post-surgery. We also, as soon as the tissue is healed, we want to start beginning nerve glides or tendon glides, which I'll show you a couple examples of. And what that does is it just allows the nerve to glide freely through the area of the incision, because now that they've created a cut in your body is going to produce scar tissue, and we want to make sure that the nerve moves freely through that tissue. In the event that you're not moving it adequately, scar tissue can kind of bind against the nerve and create a whole nother different type of compression. It's rare, but there are cases where it's happened. But usually if we can get that nerve gliding a little bit, the body takes care of itself, heals around, and you have a nice smooth tunnel for the nerve or the tendon to glide freely. Sensory regulation is important. Sometimes if the nerve has been compressed for a long enough period of time and that sensory loss has occurred, once you restore it, a lot of people wonder why it's hurting so much more after the surgery. It's because you've basically taken that kink toes and unkinked it, and now your body is responding to all the pain you weren't feeling before because of the numbness. So initially, if you get a slight increase in pain, sometimes it's actually a good thing because the nerve is now free and is receiving the sensation that it wasn't able to respond to your brain before. But regulating that hypersensitivity is important so that you can get back to your functional needs and use of your hand quicker. And just one way we do that is exposing you to different textures, different sensations, and things like that. And then the nerve will kind of regulate it as the brain kind of calibrates your nerve sensation. Range of motion is always key after a surgery because in most cases you'll be restricted by some sort of a brace or a cast immediately after the surgery. That's going to allow your tissues to stiffen up, your joints to stiffen up, especially the ones that they are crossing with the brace. And as soon as possible, we want to get you moving so that you have that freedom and flexibility that your body desires. We're made to move. Oftentimes you'll notice if you're not moving, you tend to feel worse than if you are. And that's because your joints need lubrication and mobility in order to stay healthy. And then therapeutic exercise, which we'll talk about, strengthening the muscles to withstand functional independent activities. So ergonomics, we mentioned a little bit before. That's kind of our progression through man there. We got upright and now we're back down, crunched over a computer. The most important thing is really the body's position in space. Most people end up in that famous position at the end there where you're hunched over, we're leaning forward. We, for some reason, think we can read better if we're right in front of the screen. The problem with that is our entire body is being compressed. You're losing circulation in many cases, and you're also putting an extra stretch or tension on all of your tissues. So in the picture to the lower left is more of a key alignment, what we would want to see. The hard part about this nowadays is everyone's going to smaller and tablets and phones for everything. So getting that proper alignment is much more difficult than it was when we had bigger desktops. But there are different ways to achieve it. Ideally, we want our ears over our shoulders, shoulders over our hips, hips at 90 degrees with our knees, and then knees at 90 degrees to the floor. As you can understand, that's very difficult to do if you're in a work situation because there might be 3 other people using that same station when you're not there. What we want to do is educate people in order to make smaller adjustments that are less costly, that their employers are more likely to achieve or to allow them to do. And then as they gain success with that, sometimes the employer will see that benefit and then maybe go to something like a universal keyboard that can move around or separate and get your body in a better alignment so that you're not stressed out. Most people that go in for the first time and say, I need $1,000 worth of ergonomic equipment are probably going to get laughed at and just turn around and be rejected. But if you could just do something like raising the chair and then putting some phone books below their feet so that their hips and knees are aligned properly, and you take some pressure off their back, if they're in less pain, the employer says, well, that wasn't so bad. What else can we do to help you? And they can work in smaller amounts. Also, as the doctor illustrated with the wrist positioning, the most common thing most people do using a mouse is rest their wrist on a hard surface and then back and forth toggle it for 8 hours a day. Well, you can imagine that pressure alone is going to cause some problems for your wrist, but then rocking it back and forth over a very sensitive piece of tissue, your nerve, causes a lot of problems. And then they do things like they think they're improving it by putting a cushion there, but what they do is they just push harder on that cushion, which puts more pressure on that nerve, and then they wonder why the pain's not going away. Ideally, we want your wrist to be straight, up off the surface, resting on the mouse in this case, and your shoulder and upper arm should actually be the motor that's moving the mouse. You should never use your wrist or break the plane of the wrist in order to move the mouse. And if you do that, oftentimes the larger muscles of the upper arm will be less stressed with that type of activity. Little fine movements over 8 hours, the muscles are not built to withstand that kind of activity, and then you end up having a lot of issues and inflammation like the doctor illustrated. Splinting, we talked a little bit about. So everything which we would encourage someone initially when they first start seeing symptoms to keep good alignment, especially when they're either using the keyboard or at rest at night if you tend to be that person that puts their arm or hand under their head. This is just another way to kind of keep the joints in alignment, keep better circulation to those tissues, reduce pain, and then reduce that inflammation cycle. Another common one, which we would not use for compression, but for tendonitis, is the elbow or forearm brace. Often just changes the trajectory of the tendon and where it's placed on the bone, because your tendon attaches muscle to bone. And if there's a lot of stress on that tendon all the time, you're going to get irritation. If we could change the point where that tendon is being pulled, there's less irritation, the pain or it goes away from the original site that was having a lot of stress, and usually that's a good way to adapt. And then the last one is just an example of a type of material where we might make a custom splint for someone that can't get a quite good fit, or we need to make something that is specific to a certain functional task. Some people can't do their job if they have a brace that goes entirely up to their elbow or forearm, so we might make something that just works on their hand and wrist, depending on what the issue is. So we want to maximize function, but at the same time minimize the amount of use over that tissue to allow it to heal a little bit faster. They're also helpful after certain surgeries in order to immobilize that tissue while the site is healing, which is also very beneficial. And we work very closely with a lot of the doctors, but Dr. Kilaru as well, who happens to be right next door, which is convenient. And it just works well in order for the patients to recover faster. So now into some of the bread and butter of physical therapy, which most of you probably associate is like stretching and strengthening. I've included some just basic stretches that most people neglect, although they would work wonders if you incorporate it into a daily activity. So just some basics like extending the arm, In the case where you would have a nerve compression, oftentimes doing that bent, it can be an indicator itself that you have a compression. In the case where there's no nerve compression, but you have a lot of tension, that initial sign of pain or inflammation, trying to loosen up those tissues by extending the arm, bending the wrist. If there's no pain there, just holding that stretch. Usually deep breathing is always helpful as well to relax, get more oxygen to the tissues. Most stretches, as it says in the handout, you want to hold for at least 20 seconds for that soft tissue, those fibers to actually change shape and allow some more tension in those tissues. Something down like in the left corner is called a nerve glide. We oftentimes will do that pre or post-op with a carpal tunnel patient. And those specific movements where you start with the fingers straight, bend at the knuckles, then bend a little further, and then try and do what we call a hook fist. It just allows that nerve to segmentally move through the carpal tunnel. It's usually less irritating to the patient, but it still allows us that movement that we need in order to reduce a risk of adhesions while people are healing. In some cases, it will move the nerve enough to where that compression site will shift a little bit, and so the nerve won't be as damaged in one focal point as well. The center picture is a common radial, it's called a radial nerve glide. As we mentioned, it's a little bit less common to have radial tunnel syndrome, but in some cases, if that muscle is pinching on the nerve, again, shifting that nerve a little bit can change the point of focus of compression on it and allow a bit of relief. So oftentimes, if I were to step to the side, you would bring your arm to the side, just oscillate your wrist a little bit, and what that's doing is it's gliding that nerve back and forth, and oftentimes you'll see some relief after you do that several times because we're shifting that compression point. Top right is an example of finger stretches. The bottom right is a prayer stretch, which I've included, which is a common one. And in most cases, people, their biggest determinant is time. A lot of times they say, I don't have enough time to do all these exercises. I say, well, you probably don't have enough time to have surgery either, but you're going to have to do it if you don't do these stretches. So the best thing I tell people is, in the Bay Area, we all know about the commute time. In the car is the best time in the world to stretch because we're all sitting at red lights for a half hour a day. We're all sitting in traffic for probably longer than that. So oftentimes what I say is when you're at a stop at a red light, it's a natural period of about 30 seconds. Take that time, do one of the stretches, and then when you're 2 seconds later at the next light sitting for 30 seconds, do another stretch. And that way you're not interfering with your functional daily habits, but you're also achieving the stretches and the exercises you need to stay healthy and limber at the wrist. And most people seem to like that. We talked about two types of strengthening earlier, concentric versus eccentric. This is kind of a bigger topic right now of which is better. Some doctors say concentric builds muscle faster and stronger. And by concentric, what I mean is the up phase. So if you think about your exercises, a standard bicep curl, if you will, you start with a weight in your hand, you pull it up towards your shoulder. That causes a lot of strain on the muscle, breakdown, the muscle heals, and then it's stronger. The problem with that is bringing it up causes a lot of stress on that tissue. So in the case where you're already injured, that might be too much stress for that tissue, cause more irritation, and then you say, oh, it hurts worse after I strengthen. The problem is we don't want you to do nothing because that tissue is going to keep getting weaker if you're not exercising it. So what a lot of doctors and scientists are saying is, let's do the eccentric exercise, which is less stress on your body. And what that is it's taking your weight, bringing it up to your shoulder passively, so you're not using that muscle, and then just slowly letting your body release that tension. So it's the downward phase of whatever exercise you're doing. So if you tried it, you would realize that it's less stress on your body. Gravity is assisting you down, but you're just slowing the rate of going down. Your muscle is still strengthening in a way. It's going to take longer to strengthen, but you're still gaining strength. And what they're finding is a lot of times where the muscle has built up a lot of scar tissue, it's actually helping to align that scar tissue better, which allows the muscle to be stronger after it's healed as well. When the scar tissue is very haphazard, it's not as strong, but when it's in a linear fashion like your natural tissue is, they find that your soft tissue is going to be stronger in the long run. And it's less aggravating, which is best for the patients. We're not going to build or create that pain or inflammation that we might have seen had we just gone and tried to lift weights the normal way. This is a pictorial of concentric versus eccentric. So it's just, in this case for your wrist, it would be bringing your wrist up against gravity and that weight, as opposed to helping you up and then slowly releasing that tension from the muscle. Both are very, very helpful. In conclusion, there's no substitution for prevention. We can't stress it enough. For every ounce of prevention, there's so much more pounds of pain. If you can do the ergonomics, the stretches, the strengthening before you get to the level of chronic condition or even post-op, you're going to be much more successful and healthy. If we could stress it importantly, that it's early intervention, it's identifying the cause of the problem earlier. Don't wait when you start to see a problem. Address that problem, whether it be going to your doctor, taking the medicine if that's their best course, or coming to therapy, and then allowing your body that time and rest to heal. Most people find it more difficult, but in the long run, prevention is actually going to be a faster recovery. It's more extreme maybe, you have to take some time to let your body recover, but it's a much better and healthier way of reducing these kind of conditions like nerve compression over time, as opposed to waiting, letting it get to an extreme level, having to have surgery, and then having to rehab all the way back from that. So for every ounce, prevention is the way to go to try and reduce the risk on your body.
All right, great. Thank you so much, Dr. Kilaru and Mark. Thank you for being here today. Really appreciate it.